There we go. Well, welcome everybody. Today is September. It is our third quarterly education for the Life Circle group. Today we're going to have a panelist of experts to help tell us a little bit about how each of our larger health systems are utilizing community health workers. So we'll start off with Madeline Sitting-Holy. She's the community health worker lead at Monument Health in Rapid City, South Dakota. She's married to her wonderful husband, John, and they have two boys, Wanipila and Magaju. She grew up on the Cheyenne River Reservation in South Dakota. She's a United States Navy veteran and holds an Associates of Applied Science in Health Information Management and a Bachelor of Science in Public Health. She is currently working on her Master's of Public Health with specialization in Indigenous Health at the University of North Dakota. After her, we'll hear from Angela Schaffelman, who is a community program manager at Avera. She manages the community health worker program for Avera, as well as the Avera Community Health Resources Center, which employs CHWs that have lived experience as immigrants and refugees, giving them the unique ability to understand those that they serve as they connect with immigrants and refugee populations of Sioux Falls with needed community resources. Angela has worked in healthcare for over 14 years, earning her BS in healthcare management from CTU and her MBA from the University of Sioux Falls. As the 2022 winner of NB Tribute to Women Community Service Award, Angela Schaffelman has a passion for volunteering with a particular love for serving populations that have struggled to be seen and heard and have overcome immense challenges. She volunteers at the South Dakota State Prison as a fierce advocate for the justice-impacted population. She also loves volunteering with NB and Dress for Success. She lives in Sioux Falls with her incredibly supportive husband, Chad, and their ridiculously spoiled pit bull, Tweety. After Angela, we'll hear from Carrie Howley. She's the Sanford RN Program Manager for the South Dakota Community Health Workers Program. She's been with Sanford for 11 years in the role of RN Program Manager for 1 year. Prior to this role, she was the nursing manager for the Sanford Watertown Multi-Specialty Clinic, along with 3 rural health clinics. She completed her Bachelor's of Science in Nursing from SDSU and received her Master's of Business Administration in 2021 from Western Governors University. With her extensive experience working with the ambulatory setting, she has easily transitioned to her new role supporting the community health workers in the CHW program. She has worked hard to gain awareness to the new role, as well as navigating efforts to successfully bill Medicaid for CHW services. Carrie, her husband Derek, and 2 children reside on acreage near Toronto, South Dakota. When not at work, she and her family attend many SDSU Jackrabbit athletic events and travel extensively for her kids' youth rodeos. We have some very busy ladies that are going to be presenting to us today. So Madeline, I'm going to get your document up and I'll turn it over to you. If I can get it up here. Are you guys able to see that okay?
Yep.
Perfect. All right. The floor is yours, Madeline.
Thank you. Can everyone hear me okay?
Yes.
Okay, thank you. So this is our first off, thank you for that introduction. My name is Madeline Sitting-Holy. I'm the community health center or health worker lead here at Monument Health. And this is our process workflow for Monument Health, the community health worker team. This is basically start to finish from when we receive a referral to the time the CHW home visit is complete. So basically, how it started is basically the case managers out of our Monument Health clinics, they are the ones who run the reports. And in the report, they're basically looking for Medicaid patients with the also Monument Health patients with the criteria of diabetes, heart failure, COPD, ERSD. And if there are 2 or more emergency department visits per month, and also high readmission risk rates. So once they are able to find patients through that report, they send a message to the patient provider, their PCP, and requesting a referral to the CHW program. And the case manager and the provider basically collaborate and create a care plan. And once the care plan is complete, the case managers themselves, they would contact the patients and basically let them know that about the community health worker plan, and like put it in the patient's hands if they would like to participate. If they say no, they would just basically support their decision and document yes. Then they would create an episode and also order a referral for our program. So, and also communicate, the case manager would communicate with the CHW team with the new patient referral. And basically from that point, we basically just look at the referral and look at the patients and basically determine if the patient is eligible for our program. And if they are, we basically would reach out to the patient ourselves and basically let them know who we are and schedule a home visit from there. And if the patient, if they say yes, then we continue with scheduling an appointment for the next 2 weeks or a week, depending on what the care plan states. And if they say no, we just send the message back up to the case manager. But from the yes, we basically move forward. From that date, we basically gather up, review the care plan objectives, and also determine how we can help based upon the social determinants of health that's already documented in their charts. And if it says smoking cessation, we then will find resources on just that and take with us to the home visit. So from there, basically figuring out how to help the patient before we even get there, and address the social determinants of health, identify any barriers that the patient may be experiencing in terms of getting to their appointments, or anything on the social determinants of health. If they have a food insecurity, we can find a way to get them a food box delivered, and so on and so forth. And from there, we basically make sure all the objectives are identified, and then we basically schedule the next visit and move on from there. And yeah, and right now we are we're looking to bill through Medicaid, so we are strictly following their rules, and our process workflow is basically developed around that. Yep. And so this work process flowchart is basically our process that we use. But as we've developed and evolved in this program, we've been basically looking for ways to work with our patients, because there are sometimes our patients are not all Monument Health patients. They come from different health centers, such as Oyate Health Center or Community Health. And we have developed a referral system to help these patients and help them on their journey toward healthcare. So basically, our CHW referrals, we have two ways we get patients is from the Monument Health clinic case managers through the Family Medicine Residency Clinic and the Monument Health case management team. And basically the Monument Health case management team, they'll basically assess the inpatient for any social needs that need to be addressed and send the referral to the CHW team. The case management referral form is used to start a CHW patient profile. And from this profile, we can determine how we can help the patient. And also if we need to send a message to any of our CHWs from other health agencies. So basically our team, we usually have a time to, we give ourselves 24 hours to, once we get the referral form, to contact the patient and make sure a home visit is set up as soon as possible, or make sure that we get an ROI signed and let the other CHW teams know about the patient. And so, basically, our process is we have been creating a patient profile for every patient that we help. This is basically to assess where CHW care is needed and how we can support the patient, and also how to review the care plan and continue the care with the patient. So in every patient encounter, the social determinants of health are addressed, and they are documented in Epic. And also through our referral process, we are able to schedule all the home visits. Also, as community health workers, we develop relationships with community organizations that support the needs of our patients, such as Feeding South Dakota, Goodwill, Salvation Army, Helpline CHW Transportation Program, the Hope Center, Western Community Action Program. And currently, right now, our focus for billing is on Medicaid. For sustainability, we're working with our system leadership team to identify what that will look like for Monument Health. Medicaid billing will be a part of that, but likely so will other parameters. Can you share the CHW forms?
Yes, let me get those pulled up. I'll go ahead and close this. Which one would you like?
The case management referral form.
You got it. Here you go. Oops. That's not the right one, sorry. Technology is great when it works. But it's probably the operator. Here you go.
So this is basically our case management CHW referral form. And basically, this is what the social workers in the hospital use when they basically have a patient they think may qualify for our services. They'll take this form with them into the patient's room and basically educate them on the CHW program, get the MRN number, get the name, admission date, discharge date, the inpatient room, and also put their information on there and what they would like us to focus on. And also they can do ROIs for us if the patient is a health system that's not Monument Health. And this is basically where we start with that.
Oops. You want the other one, Alan?
Yes.
There you go.
Okay, thank you. So this is the healthcare CHW referral form, and this is for patients that are not Monument Health. And this particular form was developed just because we have received these patients that are not Monument Health, and we wanted to figure out a way how we can just basically dot the I's and cross the T's and get as much information as we can for the other CHW team on the other side that may need it. And if we can basically help the patients while they're inpatient here, before we transfer them over to the other team, we just wanted to be as helpful as we could in that process. So basically, this is us. Basically, we would collect all the information, the MRN, the name, admission date, inpatient room, DOB, the because we knew that the other health center agency already needed to know that information. And also asking the patient, would it be okay if we spoke to another organization, Oyate Health Center, IHS, or Community Health CHW team to continue your CHW care? And if they say yes, then we continue. If they say no, and it's completely up to the patient, they can say no. And tribal enrollment, we put the CHW contact that we know from that agency in there with their phone number. And we basically go through, we make sure we get the social determinants of health address, and make sure if they have an ID, SSN card, if they're houseless, clothing, transportation, POV, public transit, hospital, PCP, domestic violence, substance abuse, dependent, cell phone, email, Medicaid, Medicare, what shelter are they staying in? Do they have any medication? Where do they keep their medication? Do they have a medication lockbox? And primary contact, secondary contact, and also the number of times that we've gone to visit them in their inpatient room. And also what we are requesting to help the patient in that moment, such as if we need to get a bus pass or a food box delivered right away. And also based on what we found with the patient, what we recommend the other CHW team to focus on. And we've mainly used this form for some of our patients have been houseless, and this form has helped us basically provide enough information to help the other team provide care. Yep, and I think that's pretty much it. But if anyone has any questions.
Any questions for Madeline or the Monument Health process? Okay. Well, thank you so much, Madeline. I really appreciate you sharing the information. I do know you've got another commitment, so you may be hopping off a little early from the call. So if you do think of something specific for Madeline, be sure to either raise your hand, I'll try to catch that, or just unmic yourself. And we're a pretty informal group, so feel free to jump in with a question. And now we'll turn it over to Angela.
Thank you. So I think I'll maybe start with a little bit more background about the CHWs themselves. South Dakota is fairly new to community health workers. Community health workers have been around the country and really around the world for quite a long time. We're just a little late to the game. We did receive a pretty large, why can't I think of the word? I'm having a moment. Carrie, tell me the word I'm looking for. Grant, good gracious. Maybe I'm a little nervous too. So we did receive a very large grant, we being the entire state of South Dakota, that actually came from the CDC, went to the state of South Dakota, and then to CHWSD, which then manages that grant. And so we were able to then fund CHWs from that, and that's funding both the position and also schooling to kind of help us with that basic initial investment until we can start to prove really the worth of the program and make sure that it's sustainable. So community health workers are they do fairly similar work depending on where they work, but each organization has hired them in different ways. So I know that Monument and Sanford use them slightly different than what Avera does. So Avera has a couple of ways that we use them. We have some in a couple of outlying places. So like we have one in Aberdeen, we have one in Brookings. The one in Brookings really focuses on behavioral health. We've got two at Avera at home. We have one inpatient and one outpatient behavioral health in Sioux Falls. We have an OBGYN community health worker, and then we have more what's called the resource center. So I'll talk a little bit more about that. CHWs. So we have 4 full-time at the Community Health Resource Center here in Sioux Falls. And then we have 2 community outreach consultants that work basically from the hospital that are more hospital based. So you can tell that we have a little bit more specialty specific CHWs than maybe some of the other locations do. Referrals for us come in different ways. So a lot of primary care provider referrals, a lot of clinic referrals. We also receive referrals from specialty and also in the hospital. So as a social worker or case manager sees a patient that they think we can help with, they'll refer. So when you think of what can we help with, basically it's just a connection between healthcare and resources outside of healthcare and the patient. And so how can we help that patient? So all 3 systems have community health workers, and then there are also community-based organizations that also have community health workers. So that's caused a little bit of just us trying to figure out who does what and how that works. So we're still working through that. But this grant is kind of coming to an end in 2024. And so I think all of our systems, like Madeline said, are working on how can we make this sustainable. So we're also billing Medicaid as we can. It's a little slower than we would have liked. Medicare has a proposed rule out to start paying and reimbursing for community health worker time. So we're hopeful about that. We should know in November if that's going to start. Other than that, that's just the basics of community health workers. I think instead of talking about what we do at the clinic, I'll talk more about what I know. I just took over for the community health worker program a couple of months ago. So I'm still going to claim that I'm new and still learning. But I know more, I think, about the Community Health Resource Center. And I think it's a unique way to use community health workers that I'd just like to share about. So as I said, we've got now 5. We just hired another one yesterday that work full-time out of our Community Health Resource Center. It's located in the old or the former School for the Deaf building in Sioux Falls, right next to the Empower campus where a lot of the nonprofits are. Avera leadership had said back when we were talking about this, how can we really meet patients where they are, especially those populations that are underserved? So we really started to focus on the communities that are from immigrants and refugees, and how can we make sure that those needs are met? So it was intentional that we chose this space. We wanted to make sure that we met them before healthcare. So before they start to use the ER for primary care, we wanted to really make them feel comfortable. So the building that we're in actually houses quite a few businesses that serve the African community, which are a lot of immigrants and refugees, and a lot of Smithfield employee families. And so it just happens that people know this building. So when you say kind of where to go, people just know where it is and trust it because they trust the other businesses. It's been a huge learning curve for me because obviously I'm not from that population of people. So we have hired really, really incredible community health workers that really have been community health workers in their communities for years without even having a title or a paycheck. So they are just trusted members of their communities, which really is the intent of a community health worker, to have them have some sort of a lived experience of the people and population that they're serving. And so all of our folks have come from other countries. I think the last count of languages, they speak 16. We always joke when we introduce that I speak one, and we also have a competition between languages and how many kids people have. And so Aluda just had her 7th baby, so she wins that. And then God bless Moses. Moses Idris, if you know him, he feels a little bad for me. And I'm like, I have no kids. And he says, it's okay, Angela, you have Tweety, which is my dog. So I appreciate that. We just have a really, really close community here of community health workers that really focus on cultures that are not the cultures that we generally see here. So we do that in several ways. We meet people like at a clinic appointment, we go to their homes. Community health worker really is intended to be in the community, but we also serve quite a bit in the hospitals. So say a person speaks a rare language that's really hard to find an interpreter for. Some of our folks have served as a community health worker when that patient wakes up from surgery. And so they can wake up and have someone that speaks their language. And then also really translates not just language, but culture. So what are their cultural beliefs and norms? And so we've done a lot of work. We've worked with a lot of the organizations, like Madeline had said. We just have to really communicate with those outside organizations. We work a lot with the police and the fire department to make sure that really everyone is understanding the cultural differences that happen with the immigrant refugee population. So we've just had a really successful experience with those populations of people that maybe haven't felt seen and heard before. And I feel like what we're doing here is a little unique to the community health worker program, but also really meets a need that hasn't been met before. And we've noticed a lot of difference in language and just a lot of barriers that they have that people might not understand, and that really providers don't have time to understand. And so I know that to talk about like end of life care and things like that, culture has such an important place there. And so if there's ever anything that we can do to help with those understandings, even if we don't have a CHW from that culture, it's been just a huge impact for someone to really sit down and ask those questions and understand why culture and community can look different for different populations. So I just would encourage that if there's questions or anything that we can do to help support, especially in that time of need, please feel free to. So I'll let Carrie speak, but happy to answer questions too after the fact or now.
Well, hearing none, I can dive in. So again, thank you for the introduction. Again, I'm Carrie Hawley, representing Sanford here. Both Angela and Madeline have covered a lot because even though we all have different models, there's still a lot of crossover. So you guys have shortened up my spiel significantly. So thank you. I guess I'll start with just kind of talking about with the grant. So the health disparities, the CDC grant. I manage the program here in South Dakota. We do have CHWs across our enterprise in North Dakota and Minnesota. They are being used in different ways. So what I speak to is just how we are using our South Dakota CHWs. So we took the approach of an ambulatory care model. And with that, what that means is we embedded the CHWs in our primary care clinics so they could work closely with the providers and the RN care managers and be a part of that team, although non-clinical part, but they could help kind of bridge that gap between the patient and their needs, maybe more on the community, and why those needs are becoming barriers to their healthcare. And so we put them in the clinics. We have 10 total. So we have 10 across 9 locations. We've got Aberdeen, Brookings, Chamberlain, Mitchell, Vermilion, Watertown, and then 4 here in Sioux Falls Metro. And then through the grant, we chose the route of billing Medicaid to kind of vet out the sustainability from the billing aspect. So with that, all 10 CHWs have gone through the certification course, and then will be required to continue continuing education. They are a very unique, diverse bunch with different backgrounds, different degrees and work experience, but that has been, so coming from managing nursing, you know, everybody has a nursing background. So working with this group and just the amount of knowledge and experience is really incredible. And the ideas and different thought processes. So that's been a really huge strength for that program. So like I said, we are billing Medicaid. And so then kind of to how Madeline talked, you know, you have to have a process in order to do that. So the Medicaid PCP has to place the referral for that patient. Now we get requests from many different sources. We just have to do that extra due diligence then to locate who the primary PCP is and ask for the referral. And then I'll just make a quick note that we see both our Medicaid patients can have either primary Medicaid or some secondary Medicaids will still cover. So again, we are also hoping to have that additional Medicare piece come in. That would greatly expand our population that we get to serve. So the referral, when we get that request, that'll come in, and then that provider right within our Epic electronic system will place the referral, and that inside that referral is basically the care plan for the patient. The CHW will call the patient and kind of do a pre-screen, high level of that social determinant of health need, and set up an appointment. We will see them, you know, out in the community or in their home. We prefer their home. They aren't always wanting us there, and that's completely fine. And so we'll set up that and then kind of get an idea of what some of that low-hanging fruit is, some of their, you know, Maslow's hierarchy of needs that they need to address first. Is it, I'm going to be evicted by the end of this week, or I can't take my diabetes medication. So we will kind of get a pre-screen and get some resources and then meet them and go through it. As they work with the patient, they do go through that social determinant of health wheel more extensively. But and they've also all been trained in Better Choices, Better Health. So they have even though they aren't clinical, they do have a background in just some general health training. Now, what we found is kind of what I said before, that low-hanging fruit. Our patients are dealing more with transportation, finance, housing, food. So it really, social determinants of health is a huge part. Having said that, you know, we do assist them with navigating the transportation or helping them navigate Medicaid for transportation reimbursement so they can get to their appointments. And that's some of the measurements that we're doing is just ED utilization, clinic utilization, or no-show rates, increase, decrease, things like that. We also have a large amount that we connect just to legal services. So there is, you know, legal services here in Sioux Falls that things from just arguing disability. So they've really just had a huge impact in the work that they're doing. The other thing I would just point out, we have a large non-English speaking population that they serve, and it is amazing how many entities do not have the ability for translators. So, you know, thankfully enter the CHW who can be with that patient. We use Language Line, we get that interpreter going, and then they can kind of help navigate that. You know, we had somebody going through collections because they got a letter in English, they call, there's no option for English. So just those, I mean, it seems so simple, but just those barriers, and if you don't know how to navigate that system. So that's been a large part. I talked about the Better Choices, Better Health. You know, a lot of the health promotion and education for them, they work, as I said, with the RN care managers, but they can provide an insight to that RN care manager or the provider of what they see inside the home. So maybe it's, you know, I was there and I just noticed a ton of canned foods, or we had one gal who was diabetic. All she could afford was going to the fast food and eating 1 cheeseburger a day. So identifying those things, and some of it too was, you know, reading literacy. They might be able to read, but reading comprehension. So then they aren't taking their medications because they don't know how to truly take their medications. So pictograms, different types of education tools. I would say, and I think the other two could speak, the CHW has a very different relationship with the patient than the provider, the nurse ever will, because they're coming into that home. There is a bit of guard let down. And so, you know, we have a lot of pride, and it's not always easy to tell your doctor that you can't read or can't understand. So that's been really huge in just having those eyes and ears on the ground. So that's how we here in South Dakota are using the CHWs. And yeah, we'll be wrapping up the grant here in 2023, or excuse me, May of 2024. And hopefully we'll be able to get, you know, not only Medicare, but some other payers on board for this service to expand our patient populations.
Great, thanks, Carrie. Any questions for any of our panelists? You know, Carrie, you mentioned some of the metrics that you guys were tracking. Are there other metrics that you guys are tracking that you report back to at the end of the grant?
Yeah, we are actually tracking some quality measures. So BMI, PHQ-9, kind of prior and post CHW intervention. Blood pressure, A1C would be. We also have, you know, with the billing aspect, we will drop, you know, Z codes. So that's a billing code for social determinants of health. There's, I swear there's thousands of them, but there's kind of a finite list that we're using with Medicaid. With that, we're also kind of tracking what our Z codes are and where. So if it differs between Chamberlain versus Sioux Falls. Now, most of them still are coming up with, you know, transportation, housing, and food. But as, you know, service area grows, I think we could probably start to determine, you know, going into those communities and say, hey, this is a huge need in Aberdeen, and what can we do to help that?
I'll say too, Avera's tracking quite a few different things depending on the CHW. So like the OB CHW will track different things than the Avera at home CHW, for instance. But also some of those main things like Carrie had talked about. I think what's hard about this especially, and I would love to hear what the others have to say about it, but it's really, really hard to prove the worth of something so quickly, like a saving of ED visits, a reduction. So usually for our staff, at least initially, as soon as someone starts working with the CHW, they start to learn about the importance of healthcare. So their primary care visits might go up, and so might their ED visits. Eventually, we see that long-term effect, as we've seen with other programs like coordinated care. It just takes quite a long time to be able to track that and track that accurately. So we're feeling a little rushed in this time frame to be able to really prove the worth of the program. So we're trying to look at other ways of what does it mean when you help someone sign up for Medicaid? What does it mean if you help someone find a job and they're able to provide for their family? And so it's just looking, I think, at the data a little bit differently than we had before.
Other questions?
This is Sandy Dealeman with Avera. For Sanford and Monument, what is the vision for your programs after the grant expires in May of 24?
For us, that's really what year 3 is determining, and that's what we're tracking with both the billing and then the quality metrics. So that those things haven't been decided yet. Kind of back to Angela's point, it takes some time to get data. The stuff we have is preliminary because we've been seeing patients for right at a year. Still have, you know, we're going to use what we can left,
Right.
but yeah.
Okay.
And I would like to share the same because I would say it's been about a year since basically planning and then finally getting our hands dirty and getting out there into the field and basically seeing the community for what it is and how to help. And that's basically how we've developed these forms, is basically getting out there and getting our hands dirty. But at the same time, I don't think, well, at this time, it doesn't feel like that's enough information to prove what we're trying to prove right now. But I mean, we're still trying. I still love what I do. You know, I still love helping people. So for me, I feel like it's rewarding overall just to be impactful in someone's life and also in my community.
Thank you.
Curious if any of the three programs have an existing relationship with a palliative care team in your area, or have worked with a palliative care patient or hospice patients? And then if so, what kind of training do you provide to the community health workers around end of life?
Well, I know we had the director of palliative care come and speak with our CHWs. We don't necessarily, well, I guess we do have one right now who is on home health hospice. So yeah, they had provided education because we knew it's not a matter of if, but it's when we will have patients that are on hospice or a family member on hospice. So we don't have a ton of experience, but we did receive education, I guess, from within Sanford on the program and the process, and really good education about bringing them in sooner than later.
I love that you asked that. And I actually love that you reached out, and I thought, gosh, what a perfect opportunity, especially I think in some of those cultural pieces. So we've had a couple of instances where we've helped with hospice, but more in a cultural way than anything. So for instance, there was a patient that the family did not want to tell the patient that they had a certain diagnosis. And so we were able to received a call from our ethics committee to say, we need some help here. And so our CHW was able to kind of transition that into a good conversation that ended up that they did tell the patient. And so experiences like that to really understand the differences in culture and belief and respecting that without trying to say you're wrong is a really, really powerful thing. And so we've worked several times with our hospice folks to really address that culture piece. But I think even without the culture piece, what a great opportunity to meet people where they are.
Absolutely. I know, Madeline, when you were talking, it sounded like you gathered referrals from disease diagnoses, ER utilizations, and to me that just many of the diseases that you're looking at would benefit from palliative care at some point. So I was just curious to see if you guys have worked with them at all as well.
Yeah, so we have not received any referrals yet, but we are open to referrals, and we have all received training on end of life care as well, which I thought is awesome, because for me, starting out in this role, I feel like all training is necessary, because it's just nice to have that training and to know how to approach a situation with sensitivity and just to understand with empathy and compassion the patient and their family.
Absolutely. Are there, I keep asking questions, sorry, anybody else that wants to jump in here? But just curious, you mentioned that there's ongoing training requirements for the CHWs. Where do you guys get your training at?
So there's a program at Lake Area Tech, Southwest Minnesota. I'm think I'm looking at Carrie or Madeline.
Minnesota West.
Oh, Minnesota West.
Mhm.
And so I think as far as our CHWs, they have been able to decide which schedule works best for them and kind of how they want to learn. And then with any extended education that they'll need, conferences and things will count for those.
Great. Any other questions? Well, not hearing any at this moment, I just want to say thank you to Madeline and Carrie and Angela. Really appreciate the overview of the program. The cultural piece, that trusting relationship that happens and forms with the CHWs, I think is critical. And to have that communication with their medical team, for the people that are in the home and seeing the whole person, I think is really going to help with some of those serious illnesses that happen because things that there are unmet needs in the community. So it's a great program. Thank you guys for your presentation, and this recording will be posted on the Life Circle website. And then I do have Madeline's documents, so I will make those available to the Life Circle members as well. So if you have other questions, make sure you get contact information as well. So really appreciate your time and attendance and your passion for what you do.
Yep. Thank you. Thank you for the opportunity.
Thank you.